My name's Mark Ainsworth-Smith. I'm known as Maz, and because I work for South Central Ambulance Service, which is SCAS, it's Maz from SCAS, which is quite easy to remember. Now, just so I've got a rough idea, anyone working for ambulance services here? Fantastic. Anyone working for acutes? Yeah, brilliant. And I guess some in the community as well? Yeah, brilliant, brilliant. Okay, that's fine, thank you. It's just so I've got a rough gist, which would be great. So I'm going to talk about IPC for first responders. And before I even start, I'm going to put a disclaimer up there, which is I'm not an IPC expert. You'll see I've got my watch on. I'm not bare below the elbows. You wouldn't want to see me bare below the elbows, but there you go. And in one of the pictures, I've noticed I'm in level 2 with a watch on. So you'll notice that I'm not an expert, but I am a frontline responder. I go to an awful lot of 999 emergencies. Often some of the very worst ones, the road traffic collisions, the cardiac arrests, etc. So I feel quite well placed to deliver this session in that I'm going to these type of emergencies all the time. And I've also been here during the COVID the last 2 years. So inevitably there's going to be a bit of a focus towards COVID. So the aim in 25 minutes is to cover infection prevention and control guidelines specific to pre-hospital care. One of the things that's worked really, really well across all ambulance services, in my view, is that everybody has been doing the very same thing. As soon as you get chinks in the armour there's been a problem. And although we're starting to see differences now, from the start, I think that's worked incredibly well. But there are guidelines that I'd like to go through. I'm going to talk about some of the key challenges in the pre-hospital world. I feel well placed to say this. I worked in hospital for 17 years and I've now worked pre-hospital for 18 years. So I sort of see it from both sides. I used to work in A&E, I worked at St George's for 9 years and things like that. So I can see it from both sides, okay? And I'm also going to talk about my experiences of working in PPE, which actually, if I'm honest, I'm still quite traumatized by some of the incidents that I went to, and I'm sure some of you who have responded as well have felt the same thing. It's been quite an awful time. Inevitably, this presentation will be focused towards COVID-19. I have got our infection control team in the room, so if you ask any technical questions, they'll be able to help with that, but I'm just going to talk about the practicalities. So, for anyone who does their requals, every year I have to go into our training school, and I have to go in there and I have to be certified as competent at doing a resus or dealing with a major trauma. And there is a mark sheet, an OSCE sheet, which we all have to go through. And there are some things that you must tick. And if you don't do that, then you fail and you have to come back. And you can imagine when you're the consultant, that's not great, okay? It's a bit embarrassing when that happens. When you go in there, you get your danger response ABC, Dr. ABC. I think most of us are familiar with that. And danger to me, when I've gone into any previous OSCE in the last few years, I walk in there, I go, I'm going to put my gloves on, I'm checking there's no assailants with mad axes hanging around, and I'm going to just make sure that there's no scaffolding hanging over my head. Brilliant, I've ticked the box, that's danger sorted, I've got my tick, I've passed that section on the OSCE. The reality is so very, very different now, and in the last 2.5 years, that's completely changed. We never really thought about danger. It was a token gesture, gloves on. Probably that was about as much as it was. Does everyone agree with me? I don't ever see aprons, and to be quite honest, I don't remember any training at all prior to COVID about PPE and what you should and shouldn't wear. Okay, and I think that that is a transition that we have moved on massively within the last 2.5 years, and that's really raised the profile of our IPC team. This was new. COVID hit us really quite quickly. It was unexpected. We just weren't expecting it. At Christmas 2019, none of us knew what was coming really. We started to hear the odd reports from Wuhan, but staff were unprepared and untrained for wearing PPE and dealing with a pandemic. And certainly in my organisation, we just were not ready for this. I don't know, does anyone feel they were ready for it? I think overall we all feel the same. Ambulance services did not initially have the required PPE. I'm a 3XL, I'm one of those fat blokes. There was only like 10 suits in the whole trust, and if you got called to 3 jobs in a day, which was happening at some times, you very quickly ran out of PPE. So we were really, really short of PPE for certain sizes, particularly in the extremities, the very, very small and the very, very big. But I think we were finding the same thing, and indeed we were responsible for some of the movement of equipment around the trust. We had the military helping us, and we were bailing out some acutes as well when they were running low on PPE. We were sharing things. So I know it wasn't just a problem with the ambulance service. The IPC service, the ambulance service, IPC, was seen as far less important than it is now. I've done that to be politically correct, but I think now it's right at the top of every board meeting. Indeed, I know the SCAS board were meeting today to discuss PPE levels and everything else that goes with it. This is right at the top of the agenda, when before it was perhaps about hand hygiene audits or other things that perhaps weren't really particularly interesting or sexy, in my view. Now that's completely changed, and IPC is right up there now. But it's not that we hadn't been warned. If anyone remembers, in 2009 and early 2010, we had H1N1, swine flu. That hit. And I remember working out on the front line then, and it did actually feel quite similar. We were all getting quite scared. But the good thing was that what we got for training is we got a plastic box full of masks put in the boot of our cars. And so we were going to be safe, and that's how it worked. Again, there was no real training, so there were some warning signs that we might be entering some sort of problem, but we didn't learn from it. And for anyone who remembers an organisation with a memory, which was a really interesting paper from many years ago, it's absolutely vital that we remember these lessons so that we then can use them in the future. So this is quite interesting data. On the left-hand side here, this shows you almost this explosion, and it certainly goes up exponentially in COVID cases in wave 1. What our analysts have done is mark certain things like when masks were enforced and everything else on there. And you can see there's this huge rise. Now, we were extremely fortunate in that we weren't the first wave. London, if you remember, hit first. And this mapping is actually very interesting. I'll talk about that in a second. But London was a bit of a warning for us all. What that gave us was a 6-week window where we knew what was coming, but it hadn't actually come. So we could get, for example, our fit testing done, because everyone, you sort of forget all these things, but no one was fit tested within the organisation. So we could get the fit testing, and we could also get hoods for those people that weren't able to be fit tested or didn't pass. Okay, so there was a lot of work. We did some education within that time. We were really, really lucky that we weren't in that first big bang like London Ambulance Service were. The other thing that we have now, which we didn't have then, is amazing graphing. And you can see here what they've done is, this is our business intelligence team. They're mapping our hot zones for where we're going to see COVID. And you can see why that's so important. For example, if we've got hotspots, so you can see to the west of London is a hotspot, Southampton and Portsmouth, and Milton Keynes, particularly at this time, were hotspots. We're moving extra PPE to those types of areas, and potentially you could even increase the training to staff within those areas before it became pandemic across the whole area. Now, our execs were very keen that we learned lessons, and in September 2020, they did actually a very good project, which was where they went out to staff and said they used this thing: adopt, adapt, abandon, and. So, adopt, what's worked well and what should we keep? Adapt, well, it sort of worked, but it could have worked better. Abandon, just get rid of it because it was a complete waste of time. And, so that's some people, and all the good ideas are out there with our staff. They generally have the right ideas. So they used that sort of model to decide what we could do and what we should get rid of, etc. But it was really quite disappointing to see that the main negative feedback from our frontline wasn't that they were unprepared, which is what we were expecting. It was that they were bombarded with constantly changing IPC and clinical guidance. And I'm sure everyone working in the ambulance service probably picked up on the same thing. Everyone was complaining, oh, we get all these hot newses, we get all these clinical memos, we get far too much, we can't remember them all. I think everyone's probably been in that situation. And you can sort of see why. This is just a list of our internal memos that went out to our staff. You can see, for example, there's messaging about not conveying patients in cars, and there's stuff about self-isolation, and there's priority testing for COVID-19 and getting our staff tested first. There's all these sorts of things in here. There's also some national changes, and I noticed in the middle here, between the 10th and the 19th, we actually had 4 changes to national guidance, which was a nightmare. I remember staff saying, we've had 2 changes in a day here, you know, and it sort of made you feel a little bit insecure because you weren't quite sure where you stood, if I'm completely honest. So that was interesting when we got feedback from our crews, and you can sort of see why. But actually, if you think about it, our guidance until very recently hasn't actually changed since April 2020 in terms of our frontline management of patient emergencies. It's been pretty much the same since April 2020. So this, obviously we have been using national guidance, and actually most of the time things have worked very, very well. Where we have had issues is where other ambulance services have perhaps moved in a different direction, and then rumour mill gets around. The crews start bouncing ideas. Oh, do you know what they're doing in LAS? Or have you heard what they're doing in CCAM? Once you've got that sort of rumour mill, and this is where having this sort of standardised guidance worked really, really well. So level 2 is worn still in SCAS at this stage as of today for all patient contact. As of today, I think there is about to be a change, but if I'm going to a patient, then this is what I'll wear. So level 2 PPE is worn as a minimum. We wear gloves, apron, a fluid repellent surgical mask, and if we need it, and we consider that we might need it, then we're going to use eye protection. People quibbled this and said, is this enough? I think we probably all got that. But it was felt that it was safe to use when performing chest compressions and using a defibrillator. And I am going to talk a little bit more about that, because actually we had to change our cardiac arrest process as a result of this. Level 3 was in a completely different league. Level 3 was obviously the full Tyvek suit, gloves, FFP3, or in my case, a half mask, eye protection or visors. And we use that for all aerosol generating procedures that we do. The ones that are relevant, and I know there's a list of 13 different AGPs, you know, giving saline with tracheostomies and all that sort of thing. Those aren't really relevant to the ambulance services. Manual ventilation, including use of a BVM. So that's quite different to what we've been doing. You go to a cardiac arrest, generally you put the defib on the patient, you would clearly ventilate the patient to try and get some oxygenation. That had to stop initially, and that's been quite upsetting for crews. Tracheal intubation is actually done very rarely in ambulance services. If you try and take it away from paramedics, they will go mad. Okay, some ambulance services have done that, but tracheal intubation is a very, very rare skill. You have to do 2 a month to maintain proficiency, and most are doing 1 a year. So actually, we very rarely do that. But what we do is, for example, popping in eye gels, and many of you will be familiar with the eye gels. Respiratory tract suctioning, and chest decompression. So if someone's got a tension pneumothorax, have been exposed to trauma, and you need to decompress their chest, there's a very high pressure within their thoracic cavity. When you decompress that, it lets out this jet of air, and it was felt that that almost certainly would be an AGP. Now, the guidance for cardiac arrest, we had to change. Now, there is a slide up there on the right, which is totally unprofessional. It's my motto, drive it like you stole it, okay? Which, when you work for the ambulance service, probably shouldn't be in there. If I am called to a cardiac arrest, I will do absolutely everything I can to get to that cardiac arrest first, because it's the easiest place to be. There's a limit to what you can do. If you're first on scene at a cardiac arrest, then what we do is we don level 2 PPE. We'll go straight into the scene, assess the patient, confirm cardiac arrest, and then we'll request backup. And so if I'm doing that, I'll attend the scene, confirm a cardiac arrest, then radio through and say, can you ask the crew coming to get dressed into level 3? And all I then do is I stick a defib on the patient and I do chest compressions. I don't do any ventilation. Some people have been putting oxygen on the patients. That does create a defibrillation risk. We need to learn from that. Some ambulance services, including our own, have had pretty big disasters where we've had fires as a result of that, okay? So we have actually said, just put a mask or a cloth over the patient's face until that person arrives in level 3. Totally different. Some people may ask me about survival rates, whether that's affected it. I think it has. If you look at our ROSC rates, our return of spontaneous circulation, I think they have significantly dropped as a result of that. But it may be that those patients were more sick because of COVID. So what we're going to do is we're going to avoid any AGPs. In theory, I can actually put a nasopharyngeal airway down, or I could put in an OP airway if I wanted to. But I certainly couldn't ventilate, and I couldn't use a BVM. If it's a dual crewed, so obviously some of our crews are dual crewed. That's very rare in SCAS that we've got 2 paramedics on every vehicle. We normally have an ECA, an emergency care assistant, which is like an HCA. They offer an amazing role, but they're non-clinical, working alongside a paramedic. And we actually change things very much here so that the paramedic would get changed into level 3 PPE, whilst the ECA went in and did what I do, which is the chest compressions and sticking a defib on the patient, and that's all they were doing. So we did have to make some changes to our equipment to make sure that was safe, and I will cover that in a second. And we always make sure that another clinician also goes to cases of cardiac arrest. So wherever possible. During COVID, we actually had COVID cars. So they were staffed by team leaders who were expertly trained to don and doff PPE. They carried the whole reserve of PPE, and they would come out to every accident scene or every incident scene and would come and support the staff. And there was something really positive about that in terms of emotional welfare as well. Having a senior member of staff at the scene was really good. To make it easier for crews, this was, I think, originated from London Ambulance Service, but we nicked it, borrowed it, and rebadged it, as we do, because all the good things have to be reused. But this is available on EPR, Electronic Patient Records, and what that means is that our crews have got easy access to it, and many of them were laminating it, putting it in the vehicles, so that they had clear roles about what to do if they were on their own at the scene. There's also some really useful information here about where you put your equipment, because what you don't want to do is knock out your equipment so that you then can't use it for the rest of the day. So that's quite good. And there's also some stuff about donning and doffing, etc. Working in a hospital, and I can say that, as I say, I used to work in A&E, so I know it very well, is very different to working in the pre-hospital world. Here we have a relatively controlled environment. If things are going wrong, I can pull a button and a load of staff are going to come down and give me a hand. I think we'd all agree. And also, it's pretty warm. Everything's good. Here, this is a different scenario. Here, we're very lucky. We've got the air ambulance team with the patient. But actually, as you can see, you're outdoors, so straight away it could be cold. It could be really, really hot. The worst ones I've ever done have been when it's really, really hot. You've got potentially rain. You've got all these other factors in there. So it's a very, very different world working in the pre-hospital world, and does offer certainly a lot more challenge than working in a hospital environment. So having been to several terrible road traffic collisions, including fatal accidents, in the summer, when we were wearing level 3 PPE, I'm going to sort of talk through how I found it. It was hot, really hot, and you ended up getting really stinky. It really did. I mean, literally, you could wring out your top afterwards. The masks are claustrophobic, and I know everyone says you can breathe normally through them. You can't. If you exert yourself at all, you really feel that you can't breathe. And I'm not a panicky type of person, but I really genuinely felt like I was suffocating. And when you're doing a handover, for example, to the air ambulance team when they arrive, you feel like you're completely running out of breath because you've been exerting yourself and you just don't feel you can get enough air in. I've already said that we haven't got just paramedics on our vehicles, we've got ECAs. It's very difficult when people are in level 3 PPE to know what skill grade they are. You haven't got a Scooby. And because we didn't have enough PPE, you hadn't got a chance beforehand to write that you're a paramedic or an emergency care assistant on there. I managed to stockpile a few extra large, 3XL suits, and I stood there, and it was quite therapeutic for my family, writing Maz on my back and Maz on here so that I was ready to go. But our crews didn't always have that option. So we saw some really significant errors where crews, you couldn't identify them. I still don't know who I was speaking to at jobs even now. No doubt at all your vision is impaired. It only takes about 30 seconds of doing chest compressions before you can't see. And even worse, the salt then runs into your eyes, so you've got blurry vision that you really, really cannot see, especially on a hot, sunny day dealing with a motorcyclist in the middle of Basingstoke. I can tell you that really does create some challenges. Communication challenges. If I said to you, can you give some what does that mean? Is it amiodarone? Is it adrenaline? Again, we've had drug errors where people have been so muffled that you can't actually pick up what drug they're doing. So we've had to sort of really be careful around communication. Communication with colleagues, i.e. checking drugs, just normal chit-chat, checking or talking to families. And I remember going to an utterly tragic cardiac arrest where sadly a woman had died, and I was breaking bad news. And I think they're probably still traumatized from that event even now, and I know I certainly am. And dehydration is a real risk. Literally at one of the jobs I went to, I was tipping salt out of my boots. Literally, I had, and I'm not that sweaty a person, but it is almost impossible to work in that environment. We did have some challenges, nomenclature. So hot zones versus cold zones. Some hospitals had hot zones, some had cold zones. To get around some of this, and you literally had separate entrances at the EDs as well, and separate entrances again for children, which just went completely confusing. We even had a child in cardiac arrest taken to an adult hot zone because no one knew where to go and there was no signage up. So these are the sorts of things that you might possibly see. We had red zones and green zones, and what we did do is we tested some patients before we went. We had a really good initiative in Oxfordshire, which is where we did lateral flow tests on patients where they weren't time critical and could give consent, and we tested them so that we could decide what entrance to pop them into, which I think is really good. Level 2 and level 3 was different in hospital. Our level 2 was different to what the local hospital in Southampton was doing. Level 3 was completely different, so we were like, you can imagine that was really, really awkward. And we also developed this hybrid, which many of you will have heard of, which is PPE level 2.5, which is kind of a bit of level 2, a bit of level 3, and a bit of guesswork, if I'm completely honest. And a lot of the crews were going in with an apron on and a face mask, and you're like a proper half mask, and you're like, what's going on here? But that's what they were doing. They were sort of trying to make it up as they went along. So level 2 level 2.5 was something that we quite commonly saw. And we did see some guideline anxiety. The Royal College of Anaesthetists decided to challenge whether CPR was an AGP or not. The damage that did was absolutely huge because suddenly all these crews were like, well, they're anaesthetists and they really know what they're talking about. So you had to get this sort of national steer, which obviously came from PHE. So that caused us some real anxiety as well. In terms of vehicles and equipment considerations, well, we're totally reliant on Make Ready. So we're very fortunate. We've got a company called Make Ready, part of Churchill, who come in and basically tidy our vehicles and do, because we're far too posh to wash in the ambulance service, as you can imagine. So we have to rely on these poor people to come in on a basic wage to come in and literally clean our vehicles for us. But they do daily cleaning and checking of the vehicle, so they'll make sure it's all wiped down and clean. They also then check that all the equipment's there, the defibrillators working and everything else. They do 12 weekly deep cleaning as well, also known, I'm told, as periodic cleaning. And they will do that 6 weekly on our patient transport vehicles as well. Deep cleaning after AGPs. Now, that was definitely an issue for us. What we were doing is we were going out to a cardiac arrest. The vehicle will be taken back to an ambulance station where it would sit, sometimes for 3 or 4 days before we were able to find staff to get in there and clean it. And of course, the Make Ready teams were going down with COVID as well. So that meant we had VORs, as they're known, vehicles off the road. And that meant that we had even more challenges because we didn't have enough vehicles to go around. So you can imagine the challenges there. And we also, as I mentioned, we put the ECAs in first, the emergency care assistants in first before the paramedic, whilst the paramedic got changed into level 3. So we had to reconfigure our defibrillators as well to put them into AED mode so that a member of the public or anyone can use them, because otherwise they're in manual mode and you have to decide what joules to give and everything else, and that's not a job for an ECA to do that. That's a hard enough job for a paramedic. So in this situation, we actually had to get our defibrillators completely configured to do that. So in terms of returning to normal, at the moment we are compliant with ACE and NASPIG working safely guidance. In terms of next steps, we do need to move on at some point, and I know some ambulance services have perhaps moved on slightly more than we've moved on in SCAS, but I think we've got a very careful, cautious and measured approach, which I think is the right way to go. So we're transitioning away from formal working safely guidance to locally risk-assessed guidance. There's going to be a move to respiratory and non-respiratory patients, so that's being debated at the moment within our organisation. And the level of PPE required will be determined by the on-scene triage of patients. And what we're doing is adding a sort of checklist into our electronic patient records. It's got 7 questions in there. And if somebody answers yes to that, it will recommend that you wear level 3. But at this stage, if you go to a collapse of unknown etiology and you've got no idea what's going on and they're in cardiac arrest, we'll probably be using level 3 for the vast majority. Children all through have been in level 2. And I know Claire has been having a thromby about this, but it's, I've dealt with some horrific pediatric cardiac arrests. You arrive, your emotions, especially as a parent, your emotions take over and you just crack on in level 2 and take the risk. And that's always going to be a challenge and perhaps something we need to learn from. In terms of SCAS, we're going to maintain Perspex screens in the call centres. The call centres were like bug magnets. As soon as you got COVID in our call centres, it just went rife, and we ended up with having to bubble them so that you literally had so many issues. We will also have those screens in education, training and office areas. Physical distancing no longer required on trust sites, with mitigation if we use face masks. Now, this is being debated today at our executive team, but at the moment this is the guidance. And maintain 1 metre physical distancing in break and rest areas, obviously when we're eating, so we can't wear a mask. We're going to continue good practice for no food sharing in break. The IPC police were very unpopular last Christmas. We weren't even allowed to have Christmas trees. Can you believe it? And the damage. And we weren't allowed to have boxes of chocolates and everything else. So, Claire, you'll be buying us lots of boxes of chocolates this year. And hand sanitizer, routine work areas, decontamination and symptom checks. These are all going to remain in place for now. So in summary, and our timing is good, IPC matters and has never been seen as so important. We need to make sure that we learn from the valuable lessons of COVID-19. I'm sure all of us are aware that this is likely to happen again and it could be a whole lot worse. And we need to move on now. We've kind of reached that bit. Everyone's a bit fed up of the whole thing. We do need to move on, but we need to do that safely.